lecture is Drug Therapy of Bronchial Asthma. In this part of the video lecture, we will discuss the signs and symptoms, investigations of bronchial asthma, the pathophysiology, the therapeutic goal in the treatment of bronchial asthma, the classification of drugs, and the details of bronchodilators that are used in the treatment of bronchial asthma. So what is bronchial asthma? The term asthma is derived from a Greek word difficulty in breathing. It is a chronic inflammatory disease where the patient suffers from reversible episodes of airflow obstruction due to bronchial hyperresponsiveness. However, as the chronic inflammation progresses, it can lead to irreversible obstruction of the airways. So what are the signs and symptoms of bronchial asthma? The cardinal symptoms of bronchial asthma are chest tightness, shortness of breath, wheezing, cough, and the symptoms get worsened at night time. On examination of chest, there is presence of bronchi and prolonged expiration. Lung function tests reveal decreased peak expiratory flow rate and forced expiratory volume per second. So next we move on to the pathophysiology of bronchial asthma. In asthma, when an atopic individual is exposed to an allergen, there is imbalance between T helper 1 cells and T helper 2 cells favoring T helper 2 lymphocytes. So there is exaggerated T helper 2 response, and this leads to release of inflammatory mediators including cytokines, interleukin 4, interleukin 13 and interleukin 5. Interleukin 4 stimulates the B cells to produce IgE antibodies, and also it upregulates the IgE receptors that are present on the mast cells. So excessive production of IgE antibodies, these antibodies bind to the IgE receptors that are expressed on the mast cells, and there is cross-linking of the receptors resulting in degranulation of mast cells. The degranulation of mast cells causes release of prostaglandins, cytokines, leukotrienes. Leukotrienes play a central role in the pathogenesis of bronchial asthma as they cause marked bronchoconstriction. Leukotrienes C4, D4, E4 are 1000 times more potent than histamine in producing bronchoconstriction. They cause additional recruitment of inflammatory cells, increased mucus secretion, hyperresponsiveness of the bronchial airways, capillary leakage, vasogenic edema, leading to intermittent airflow obstruction and narrowing of airways. Interleukin 13 induces type 4 hypersensitivity reaction causing inflammation of the airways and leading to hyperresponsiveness of airways and airway narrowing. Interleukin 5 activates the eosinophils, causes maturation, differentiation and multiplication of eosinophils, and also migration of eosinophils from the circulation to the bronchial tissue. In the early phase, there is smooth muscle spasm causing bronchial hyperresponsiveness, narrowing of airways and airflow obstruction. But with chronic inflammation over a period of time, there is necrosis and fibrosis of the bronchial epithelial cells, airway remodeling leading to structural changes in the airways, and finally it can lead to irreversible obstruction of airways and life-threatening bronchial asthmatic attacks. So the key points in the pathogenesis of bronchial asthma are narrowing of airways due to formation of mucus plugs and bronchial hyperresponsiveness. Secondly, release of inflammatory mediators from mast cells. Thirdly, leukotrienes playing a central role in the pathophysiology of bronchial asthma. And lastly, chronic inflammation of airways causing fibrosis, goblet cell hyperplasia, necrosis of bronchial epithelial cells causing airway remodeling and leading to irreversible obstruction of airways. So the therapeutic objective in the management of bronchial asthma is to relax the smooth muscle of the airways using drugs that act as bronchodilators, and they cause immediate relief of symptoms by causing relaxation of airways, reducing airflow obstruction and symptomatic relief of acute attack of bronchial asthma. Secondly, to control inflammation of airways using corticosteroids, mast cell stabilizers and leukotriene pathway inhibitors. The pharmacologic agents are therefore divided into two broad categories. The first category is the relievers. They alleviate smooth muscle spasm in the bronchial airways and cause relief of symptoms and are used in acute attack of bronchial asthma. The second category is known as controllers. They reduce inflammation in the airways and helps to control bronchial asthma. So how do we classify the drugs used in the management of bronchial asthma? The drugs used for bronchial asthma can be classified as follows. The first group is bronchodilators. Bronchodilators include 1. Selective beta-2 agonists such as salbutamol, terbutaline, salmeterol, formoterol. The non-selective sympathomimetic agents include epinephrine, ephedrine, isoprenaline. Anticholinergic drugs are ipratropium, tiotropium bromide and atropine can also be used. Fourth category, methylxanthines, which includes theophylline, aminophylline and diprophylline. The next group is corticosteroids that act as anti-inflammatory agents. So these can further be subclassified as oral, parenteral and inhalational. Examples of oral steroids are prednisone, prednisolone and methylprednisolone. Parenteral steroids are hydrocortisone and methylprednisolone. Examples of inhalation steroids are beclomethasone, budesonide, flunisolide, fluticasone. The next group is mast cell stabilizers and the drugs are sodium chromoglycate and nedocromil. The next group is leukotriene modulators. The drug which inhibits 5-lipoxygenase pathway is Z-lutein, and there are drugs that act as antagonists of leukotriene receptors, and these drugs are zafirleucast, monteleucast, pranleucast. Lastly, we have monoclonal antibodies. The monoclonal antibody, that is anti-IgE antibody, and the drug is omalizumab. The monoclonal antibodies that inhibit interleukin 5 pathway are benralizumab and mepolizumab. So next we move on to discuss bronchodilators. The bronchodilators produce action by acting on autonomic nervous system receptors. The autonomic nervous system is of two types, sympathetic and parasympathetic. The sympathetic stimulation causes activation of beta-2 receptors of the smooth muscle of the bronchial airways, causing relaxation of airways and therefore acting as bronchodilators. Therefore, beta-2 adrenergic agonists that stimulate the beta-2 receptors of the smooth muscle of airways cause bronchodilation. The parasympathetic stimulation causes activation of muscarinic receptors, in particular the M3 receptors of the smooth muscle of the airways, causing constriction of airways. Therefore, drugs that antagonize muscarinic receptors act as bronchodilators. Therefore, beta-2 adrenergic agonists, muscarinic receptor antagonists and methylxanthines act as bronchodilators. Beta-adrenergic agonists can be non-selective sympathomimetic agents such as epinephrine and isoprenaline. The selective beta-2 agonists are salbutamol, terbutaline, salmeterol and formoterol. The non-selective sympathomimetic agents such as epinephrine stimulates alpha-1, beta-1, beta-2 receptors. The stimulation of alpha-1 receptors increases the peripheral vascular resistance, giving rise to high blood pressure. Stimulation of beta-1 receptors of the heart increases palpitation, tachycardia, increased risk of arrhythmias. The stimulation of beta-2 receptors of the bronchial smooth muscle causes relaxation of the airways, thus reducing airflow obstruction and causing bronchodilation and producing a desired therapeutic effect. So, although epinephrine produces bronchodilation due to beta-2 mediated effect, it causes undesirable side effects due to alpha-1 and beta-1 stimulatory actions. Therefore, adrenaline or epinephrine is less preferred in bronchial asthma. Isoprenaline lacks alpha-1 action, but it is a non-selective beta agonist. That is, it stimulates both beta-1 and beta-2 receptors. Because it stimulates the beta-1 receptors of the heart, it causes tachycardia or palpitation. Thus, both adrenaline and isoprenaline act as effective bronchodilator, but they cause undesirable side effects such as rise in blood pressure, palpitation, tachycardia. So to avoid these cardiac side effects, selective beta-2 agonists were developed. The selective beta-2 agonists can be short-acting and long-acting beta-2 agonists. The short-acting beta-2 agonist produces prompt action. They produce immediate action within 15 to 30 minutes and the duration of action lasts for 4 to 6 hours. Therefore, they are given frequently, that is 3 to 4 times in a day. These drugs are good candidates for the management of acute asthma exacerbation. However, these drugs are poor candidates in the management of nocturnal asthmatic attacks or in the maintenance of asthma control or exercise-induced asthma where long-term action is needed. Also, there is reduced effectiveness of salbutamol when used as monotherapy repeatedly for a long period. This is because of desensitization of beta-adrenergic receptors on the smooth muscle of the airways. So, repeated stimulation of beta-adrenergic receptors causes desensitization or downregulation of beta-adrenergic receptors. This decreases the therapeutic effect and duration of action over a period of time. Therefore, salbutamol should not be used as monotherapy for a long period or in chronic asthma. They are very good candidates for the management of symptomatic relief in acute bronchial asthma. In conclusion, short-acting beta-2 agonists are good candidates for the management of acute asthma exacerbations. However, they are not good drugs for managing nocturnal asthmatic episodes or exercise-induced asthma or maintenance of asthma control, which require a longer duration of action. Therefore, in these situations, the long-acting beta-2 agonists provide effective control. The long-acting beta-2 agonists in general have a slow onset of action but a long duration of action of 12 to 24 hours. Therefore, they can be administered once daily. They are long-acting because the presence of lipophilic side chain increases the affinity of these drugs for beta-2 adrenergic receptors expressed on the smooth muscles of the bronchial airways. Because of strong affinity for the beta-2 adrenergic receptors, the duration of action of these drugs is very long. Since the duration of action is long, they are good candidates for the management of nocturnal asthma, for prevention of asthma attacks and exercise-induced asthma. However, the limitation is that these drugs are not effective in the management of acute attack of asthma, with the exception of formoterol, which is a long-acting beta-2 agonist which has a quick onset of action and also the duration of action is long. So, formoterol is a long-acting beta-2 agonist which can be used in acute asthma exacerbations and also in the management of chronic bronchial asthma because the duration of action is long. Also, in the treatment of chronic asthma, the use of beta-2 agonists as monotherapy is not recommended. This is because the beta-2 agonists, although they cause relaxation of airways and cause symptomatic improvement, they do not treat the underlying inflammation of the airways. Because they don't treat the underlying inflammation in the airways, the inflammation progresses and this can lead to fatal asthma attacks. Clinical studies have shown high mortality rate in patients who have used long-acting beta-2 agonists for the management of chronic bronchial asthma. Therefore, GINA report 2021 for asthma prevention and management recommends that as a reliever medication, low-dose inhaled corticosteroid and formoterol as needed can be given. And as a controller medication, inhaled corticosteroids and long-acting beta-2 agonists can be used. Therefore, long-acting beta-2 agonists are used along with inhaled corticosteroids. So, the beta-2 agonists provide symptomatic improvement by causing relaxation of airways, while the inhaled corticosteroid treats the underlying inflammation of the airways and prevents the progression of the disease and keeps asthma under control. For maintenance of asthma control, the inhaled corticosteroids have to be added with the long-acting beta-2 agonist. Also to be kept in mind that among the long-acting beta-2 agonists, formoterol has a quick onset of action and a long duration of action. So, formoterol can be used for the management of acute attack of asthma, but it is combined with inhaled corticosteroid to take care of the inflammation of the airways. So now let's understand what is the mechanism of action of beta-2 adrenergic agonists and the likely side effects of these drugs. Beta-2 adrenergic agonist stimulates the beta-2 adrenergic receptors of the smooth muscles of the bronchial airways. This in turn causes activation of adenylyl cyclase enzyme, increasing the cyclic AMP formation in the bronchial tissue. Increased cyclic AMP formation activates the protein kinase A enzyme, which causes dephosphorylation of the myosin light chain, causing relaxation of the bronchial smooth muscles and causing bronchodilation. Also, beta-2 adrenergic stimulation of sodium-potassium ATPase pump causes efflux of potassium. So, outward movement of potassium causes hyperpolarization and relaxation of airways. The stimulation of beta-2 receptors of the presynaptic cholinergic nerve endings reduces acetylcholine release, and this decreases the cholinergic bronchoconstriction. Stimulation of beta-2 receptors of the mast cells decreases or inhibits the release of inflammatory mediators from the mast cells, eosinophils, lymphocytes, and this decreases inflammation. Thus, beta-2 agonists act as bronchodilators and also exert anti-inflammatory effect due to stimulation of beta-2 receptors of the mast cell, inhibiting the release of inflammatory mediators. So what are the likely side effects resulting from the use of beta-2 adrenergic agonists? The most common side effect is tremor or shakiness. Tremor occurs due to stimulation of beta-2 receptors of the skeletal muscle, and this contributes to tremor. Secondly, palpitation or tachycardia occurs due to beta-2 induced vasodilatation and reflex tachycardia. So, beta-2 induced vasodilatation causes reflex tachycardia, leading to palpitation and increasing the risk of arrhythmias. So, cardiac side effects are more common with non-specific beta-adrenergic agonists. Thirdly, hypokalemia occurs due to stimulation of beta-2 receptors causing shift of potassium into the cells, thus decreasing the potassium levels in the body and causing hypokalemia. Beta-2 adrenergic stimulation increases the release of glucose and insulin secretion, and insulin facilitates the transport of potassium into the cells, causing hypokalemia. So, hypokalemia occurs due to insulin secretion, which is a beta-2 mediated effect. So next is anticholinergics used as bronchodilators. The airway smooth muscle tone is regulated by cholinergic innervation, and release of acetylcholine stimulates the muscarinic receptors that are expressed in the airways, namely M1, M3 and M2 receptors, and the stimulation of muscarinic receptors causes bronchoconstriction or increased cholinergic tone. Therefore, antagonism or blockade of muscarinic receptors causes decreased cholinergic tone and relaxation of the bronchial airways. Examples of anticholinergic drugs that can be used in bronchial asthma are atropine, ipratropium bromide and tiotropium bromide. Although atropine has the ability to cause bronchodilation, it is avoided, and the reason being it is a tertiary amine, So it rapidly crosses the blood-brain barrier and causes central side effects. Also, it is rapidly absorbed through the pulmonary epithelium and enters the systemic circulation, causing systemic side effects such as dry mouth, blurring vision, retention of urine, constipation, and this is problematic particularly in elderly patients. Therefore, atropine is avoided in the management of bronchial asthma. Therefore, to overcome the drawbacks of atropine, quaternary ammonium compounds such as ipratropium and tiotropium were developed, and these are bronchoselective. They have selective action on the bronchial airways and the side effects are less. Therefore, ipratropium and tiotropium are preferred anticholinergics in the management of bronchial asthma. When we compare the effects of ipratropium bromide and tiotropium bromide, ipratropium bromide has a short duration of action and therefore has to be administered 3 to 4 times in a day. Tiotropium bromide on the other hand has a long duration of action of 12 to 24 hours and therefore is administered once daily. The long duration of action is due to slow dissociation from the muscarinic receptors. The slow dissociation of tiotropium bromide from the muscarinic receptors makes the drug long-acting drug, whereas ipratropium bromide has a faster dissociation rate from the muscarinic receptors. Therefore, the duration of action is for a short period. Secondly, tiotropium bromide when compared to ipratropium bromide has superior efficacy in COPD or chronic obstructive pulmonary disease where the vagal tone is very high. The reason for better efficacy of tiotropium bromide over ipratropium bromide is related to mechanism of action. As we have learned that the airway smooth muscles express muscarinic receptors, particularly the M1, M3 and M2 receptors. Now M1 and M3 receptors are present in the postsynaptic membrane. They are excitatory in nature and stimulation of M1 and M3 receptors causes bronchoconstriction and increased cholinergic transmission. Whereas the stimulation of M2 receptors which are present at the presynaptic cholinergic nerve ending inhibits the release of acetylcholine into the synaptic cleft, thereby decreasing the cholinergic stimulation. Therefore, M1 and M3 receptor stimulation increases the cholinergic transmission. Stimulation of M2 receptors decrease the cholinergic transmission. Tiotropium bromide antagonizes or blocks M1 and M3 receptors with no action on M2 receptors. So, selective action on M1 and M3 receptors decreases the acetylcholine mediated cholinergic neurotransmission, decreasing the cholinergic output, the cholinergic tone of the airways, causing relaxation of the airways and symptomatic improvement in bronchial asthma. Ipratropium, on the other hand, antagonizes all subtypes of muscarinic receptors, namely M1, M3 and M2 receptors. So, due to blockade of M2 receptors, there is increased acetylcholine release. The increased release of acetylcholine partially counteracts the desired effect that is produced by the blockade of M1 and M3 receptors by ipratropium bromide. So, the superior efficacy of tiotropium bromide is due to selective action on M1 and M3 receptors and decreasing the acetylcholine mediated transmission and decreasing the cholinergic tone. Tiotropium bromide is considered to be the drug of choice of COPD or chronic obstructive pulmonary disease, which is characterized by high cholinergic tone and the parasympathetic pathway is dominant. But in bronchial asthma, the efficacy is less compared to beta-2 agonists. Therefore, beta-2 agonists are preferred over anticholinergics in the management of acute asthma exacerbations. However, these drugs can be used as an add-on therapy with beta-2 agonists or inhaled corticosteroids to increase the effectiveness and improve asthma control. Anticholinergic drugs can be used in patients who are on beta blockers, and beta 2 agonists cannot be used in these patients. Also, these drugs can be used in cardiac patients where beta 2 agonists can increase the risk of tachycardia, palpitation, and increase the risk of cardiac arrhythmias. So, in cardiac patients and in patients on beta blockers, anticholinergics are preferred over beta 2 agonists. Next is methylxanthines as bronchodilators. Drugs that belong to this class are theophylline and aminophylline. How does theophylline act? Firstly, it acts as an antagonist at adenosine receptors on the cell surface, inhibiting the actions of adenosine. Adenosine has been shown to cause bronchoconstriction by increasing the release of histamine from the mast cells. Secondly, theophylline inhibits phosphodiesterase enzyme, which is responsible for degradation of cyclic AMP to 5-AMP. So, by inhibiting phosphodiesterase enzyme, it increases the cyclic AMP concentration, which is responsible for causing relaxation of the airways and causing bronchodilation. Thirdly, it has anti-inflammatory actions, as it is known that transcription of inflammatory gene protein requires acetylation of histones. Theophylline, by activating histone deacetylase, prevents acetylation of histone and exerting anti-inflammatory action. With respect to the therapeutic uses of theophylline, it is not preferred for acute asthma exacerbations, as beta-2 agonists are considered to be the preferred drugs for the management of acute attack of bronchial asthma. These drugs are mostly used for controlling asthma attacks, preventing further asthma attacks. Secondly, aminophylline given by slow IV infusion can be used in the management of acute left ventricular failure where morphine is contraindicated. For example, in patients with bronchial asthma. In patients with bronchial asthma, morphine can exacerbate or worsen the attack of bronchial asthma. Therefore, aminophylline by slow IV infusion can safely be administered in the treatment of cardiac asthma and bronchial asthma. However, the use of theophylline has declined because of newer anti-asthma medications with better efficacy and safety profile. Also, an important drawback of theophylline is that it has a narrow therapeutic window. It is effective at a therapeutic plasma concentration of 5 to 15 microgram per ml. Below 5 microgram per ml, it fails to be effective, and above 20 microgram per ml, there is toxicity. The side effects are related to GI tract, central nervous system and cardiovascular system. The side effects are nausea, vomiting, diarrhea, agitation, irritation, restlessness, insomnia, palpitation, decreased blood pressure, and at higher doses it can cause seizures, convulsions, cardiac arrhythmias and also death. So, since theophylline has a narrow safety margin, the plasma levels of the drug has to be monitored in these patients to prevent therapeutic failure and also toxicity.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.